Hi, this is Dr. Diane Gayhart, and this is part 2 of my lecture on clinical assessment with the DSM-5 update. And this half of the workshop is designed to help you fill out a clinical assessment form. You can use the one that comes with the text, or actually there's a revised one, and I'm going to show you where to download that. And it's basically, I know all clinical assessment forms do look different, they're all formatted differently, but they generally have very similar components, and so being able to fill this one out should help you fill out a clinical assessment no matter where you go. So I mentioned in the first half of this online lecture that this lecture is based on Mastering Competencies in Family Therapy, and the second edition. But after my second edition came out, the DSM-5 came out about 3 months later, and so this online lecture helps update the book and the information for the DSM-5. And so this is a revised. There are revised clinical assessment forms now that you can get either from the Cengage website for the text or from masteringcompetencies.com. And so this revised form has the new formatting for the DSM-5 diagnosis, which we discussed in part 1 of this lecture. So when you begin filling out the form, or begin filling almost any clinical form out, you almost always start out with some form of client demographics and some identification of the presenting problem. So generally, when you fill out clinical forms nowadays, you'll use a client ID number rather than a full name. I mean, it just depends on the setting that you're in. But using the client ID number helps protect client privacy better, so that's why it's always preferred. Generally, you'll indicate what type of modality, whether you're doing individual, couple, family, or group work, and also to specify which language you are working in. So the general demographics for clients includes age, their ethnicity, relational status, which can include sexual orientation, and their employment and or grade in school. And sometimes there's other forms of significant information such as immigration status and such things. So, and because this is a family therapy text in particular, but for all clients it really is useful to also have some of the basic demographics of significant others, being partners or children and or parents, so you have a broader sense of the client's context, which includes their resources. And so in the form that goes with this book, we have a checklist of the presenting problems, and hopefully these should match up with the rest of the assessment. So hopefully these presenting problems fit with whatever you end up saying their diagnosis is and or whatever type of resources you recommend as part of supporting the treatment. So on this slide you can see that I've cut and pasted part of the form to just see what it all looks like. You can see the first box here, you're going to write the clinician, that would be your name, the client's name or ID number, and then again the type of configuration of treatment, the primary language. And then I have drop-down menus for all of these in terms of selecting gender, age, client ethnicity, relational status, and that includes sexual orientation on this particular form. And you can also put in their occupation and or any other identifying information. And for students, for kids, you'd normally put in their grade in school and the name of their school. And so here, by filling in this information, you get a good sense of who the client is and the significant others in their family system. And here you can see the list of presenting problems. Obviously, this is not an exclusive list, just a list of outpatient presenting problems. And here again, I want you to really pay attention to how these presenting problems are going to line up with your clinical assessment, your diagnosis, and then your case management. This is certainly, I've noticed that oftentimes people will check things off on this like depression or anxiety, and yet when it comes down to the mental status, those aren't listed. So that's a little confusing. So you want to make sure that these presenting problems are kind of lining up with what the mental status and other diagnoses are. And you certainly don't want to have problems here that aren't addressed later. But the presenting problem section is generally a place where you can kind of identify what clients have said they're coming in to work on. And you can see there's a separate list or column here for when you're working with children. So the next section of the clinical assessment form is the mental status exam, or at least the reporting of what you found in the mental status exam. And so again, here you can use the cross-cutting symptom measures to help you with this. You can use some of the suggested family therapy adaptations. You can use formal instruments, but somehow, depending on your work setting, it's going to determine what is most appropriate. You're going to want to collect information on the various areas of functioning on the mental status exam. So you want to look at interpersonal issues, client mood, affect, which affect is the expression of the mood and how the mood is expressed, sleeping patterns, changes in eating, any anxiety, psychotic symptoms, motor activity, and thought. And so these are, and there are various ways to divide up a mental status exam. These are some of the more common categories. And for this particular one, it is a check sheet, which makes it pretty easy. It's just up to you to kind of ask the questions, gather the information as accurately as possible. So here we have a little snapshot of what the mental status looks like on the particular form associated with this book. And as I mentioned, virtually every agency is going to have their own version of this. Some places you will have to write this out longhand. You won't get a check sheet. It certainly is easier doing it with the check sheet, I'd have to say, having done it both ways. But here you can get a sense of some of the things that you would assess for. So interpersonally, you're going to look for, if there's conflict, isolation, harassment, those sorts of things. For mood, depressed, sad, anxious, dysphoric, angry, irritable, manic, you can start noting those things. For affect, again, this is the expression of the mood, so it can be constricted, kind of restrained. Blunted is there isn't a whole lot coming out. Flat is normally associated with more psychotic. It's kind of an extreme lack of expression there. Labile refers to kind of up and down and all over the place. And incongruent means, and you would, to some extent we're all sort of incongruent in our affect or expression, but that would mean that they're talking about one emotion like anger, but expressing a very different one. And so there's kind of a real notable incongruency there. And here you can go through the rest of the list, I think, yourself, but sleeping, eating, anxiety, trauma symptoms are included in this particular mental status here. Psychotic symptoms, motor activity, speech, thought, social legal problems, and other symptoms. And at the end of the chapter, there is a very, I think, handy list that defines all these terms if you are not used to or don't know what exactly one of these means. So next, the next section on the form is the diagnosis, and after listening to part 1 of this lecture, you should be well prepared to do that. This particular diagnosis here includes a prompt to have you consider the contextual factors related to the diagnosis, such as age, gender, family dynamics, those sorts of things. And it has you describe the impact of these identified factors on the diagnosis. So for age, there are actually different sets of criteria you can use. There is gender notes in the actual DSM, looking at unique cultural, patterns of expression and such can also be considered a way of considering contextual factors when making a diagnosis. And then here, as you well know, that we have the DSM5 codes, and these are the ICD-10 codes, and then we have the diagnosis written out with the specifier, and this is the same diagnosis that we had from part 1 of this workshop. So the next section we have here relates to medical information, psychiatric information. And so there's a place to indicate whether or not you're recommending a psychiatric or medical evaluation, as well as listing out medications with an emphasis on the psychotropic medications that may have been prescribed. And additionally with this is a section on medical necessity. And what medical necessity is, it's a kind of formality that comes out of third-party payer systems like insurance, that basically there's an understanding that in order for insurance to pay for a service, the client needs to meet medical necessity. And that means without treatment, the client is likely to experience either significant impairment, a probability of significant impairment, or if the client is a child, a potential developmental arrest. And so this is necessary in order to deem it kind of reimbursable by a third-party payer. So depending on what work context you are in, you may be asked to document medical necessity, basically for reimbursement purposes. And when you do that, you need to specify the areas of functioning needed for medical necessity, which is generally considered daily living, so taking care of themselves and daily business, social functioning, so intimate relationships, friendships, health, so physical and mental health, work, school functioning, being able to maintain a job and or get passing grades in school, and living arrangements, so able to have a place to live. So these are important to document, like I said, for the third-party payers and reimbursement. So here you can see the place in the form where you indicate whether the person's been referred out for the psychiatric evaluation, whether they agreed, whether you used any psychometric instruments for your assessment, including the cross-cutting symptom inventories, and then the client's response to the diagnosis and or any feedback related to that. And here's where you can list the current medications, and then at the bottom here you can see where you would indicate medical necessity, and you can check all that apply. So, and again, here you have the significant impairment, probability of significant impairment, or probable developmental arrest, and then the areas of impairment. So you can just check those off as they apply to your client. So the next section is risk assessment, and this is increasingly a very important part of any clinical assessment. As it is the clinician's job to make sure our clients are safe, and that in this initial clinical assessment is one place where you do that. You also do it week to week in the progress notes, but this is the primary place where you're expected to kind of do a broad-based risk assessment. So risk assessment generally includes documenting whether or not the client has any indications of suicidal ideation, homicidal ideation, alcohol or substance abuse, child, elder, or dependent adult abuse, domestic violence, eating disorders, and self-harm. And so it's important, if there's any potential area of risk here, that you document the legal and ethical actions you've taken to ensure client safety. And once you do that, either here in an assessment or in a progress note, you want to make sure you follow up week to week in your progress notes, documenting that you're checking in to make sure that the client remains stable. So in addition to risk factors, it's important to document a safety plan, especially if any of the risk factors were identified as a problem. So some of the indicators of safety or parts of a safety plan can include having outside support persons, having the client cite reasons to live, having hope for future goals, clients willing to dispose of dangerous objects, and generally agreeing to the safety plan or contracting for services. So when, and as part of the plan, you can have a verbal or nonverbal no harm contract, and you can document it in the form, including emergency contacts or cards, phone numbers, medication management, and then specific plans for how to handle when a client starts to go into crisis. So here you have the risk and safety on the form, and you can see there's a section for identifying suicidality and the various variations of that, and these are different risk factors. So active ideation versus passive, having means or plan, having attempts in the past year, having other people, peers or family with a history of a completed suicide. Those are real significant to know about. And then you have a similar list for homicidality. And then for alcohol and substance abuse, indicating whether there is use and or abuse. And then also you have a list here of several forms of sexual and physical abuse and other risk factors. So you have a child abuse history, an adult with an abuse or an assault. In adulthood, you have a history of perpetrating abuse, elder, dependent adult abuse or neglect. A history with restrictive eating, binging, and or purging. You have cutting or self-harm, criminal legal history, and other types of trauma, including natural disasters, are important to document on these forms. So this is the section where you can indicate a risk and potential forms, potential things that could be going on with your client that you would need to take action on to keep them safe. So in terms of documenting safety in a safety plan, this form it has a lot on it to help guide you. It has indicators of safety, and these are things where you can identify some indicators of safety as well as risk, and then elements of the safety plan that you've actually negotiated. So a verbal no harm contract versus a written one, an emergency card. So you can see there's several options here for how to put together a safety plan. There's also a place to document any legal or actions you may have taken or ethical actions, such as reporting child abuse, doing domestic violence, safety plan, those sorts of things. So in the next section, you're going to document any case management that you plan to do based on your clinical assessment and or your case conceptualization from the other chapter. And here you're going to document contacting social workers, contacting other medical or psychological professionals to coordinate treatment, any referrals for evaluations, referrals for other services, social services like housing, food, group therapy, and such. Referring out for legal assistance, working with probation and attorneys, and then just generally connecting with community and support persons. So this is an overview of kind of your plan for case management that goes along and kind of fits with the concerns you identified in the clinical assessment. So here you can see the section of the form that covers case management, and it starts with collateral contacts. So these are contacts to other support persons. So you have the physicians and other professionals, mental health treatment elsewhere, and a social worker. And then you have a list of the potential referrals for like a medical assessment or for social services or for support groups or group therapy, any type of forensic or legal processes related to treatment. So this is the first half of the case management form. And then in the second part here, we see the just identifying parts of the support network, which is very important in most forms of therapy in terms of ensuring not only positive outcomes but sustained gains. So identifying the client support network of family or partner, friends, or religious groups and such. Also identifying anticipated effects of the treatment will have on the support system can be helpful in terms of your planning. And especially there's a lot of research that when the clients have significant mental health issues such as major depression or bipolar, ADHD, that involving family and partners, it can be very helpful in terms of ensuring positive gains. And then just listing anything else that the client might need to be successful. Then there is an expected outcome and or prognosis, which is returning to normal functioning, anticipating less than normal functioning, or preventing deterioration, depending on just what you're expecting with your client. And then we also have a place here to include the client's sense of hope, which is one of the common factors, which is also discussed in this book elsewhere. You'll have to read to learn more about that, but here's a place to document that and to just kind of clue you into and help you remind, what is the client's sense of hope, and is that something I'm going to need to bolster and help support in order to, have the best chance of positive outcomes. Finally, because many therapists in training are using this form, I've included a section on the evaluation of the assessment to have you reflect on how this assessment and the ideas in this assessment might be received by the client and their family system. And it's an invitation for you to kind of consider diversity issues, and if you have thoroughly considered those, considered any systemic factors, how the broader family system may be impacting what you're seeing and or may respond from what you're proposing here, and then also looking at the client-therapist agreement on the goals and or just the outcome of your clinical assessment. And this again is just an invitation for you to reflect on these factors, especially as you are developing as a therapist. And so as you can see here, this is a clip of the form that includes the evaluation as well as a place for both the clinician to sign and include their license or intern status, as well as a supervisor, if they're applicable, to sign. And so that is kind of an overview of the clinical assessment form. And like I said, most clinical assessment forms look different but have the same basic information. And I do think if you can manage to fill this one out, that you will be well on your way to filling out a clinical assessment most anywhere you go. So hopefully you found this a useful introduction to clinical assessment.